Okay. Yeah, he does connect the dots well. He's just very linear and I think very easy to learn from. So, he should be like very, predictable for the exam. So, I don't think you should have anything to worry about. All right. Let me get things going here. Okay, so I just moved over the weekend and I just got my internet set up today. So tonight's going to be um, pretty pretty quick because I'm still working my way through the material to making these tutoring slides. Okay, so anyways, let's start with the renin-angiotensin-aldosterone system. So renin is secreted in response to three things. So either a decrease in blood pressure, which is detected by Pulcosyn cells, and these are part of your renobaroreceptor, or a decrease in sodium delivery to the macula densa, or a decrease in blood pressure detected by the carotid sinus. And if you're unfamiliar, or if Pulcosyn cells sounds unfamiliar, these are the same thing as extraglomerular mesangial cells. So I think that's how you learned it in histo, but next year you may hear Pulcosyn cells. So I just wanted to throw that in there to start getting you familiar with that. All right, so let's walk through the flow over here. So you have renin, which is secreted by your kidney, specifically the JG cells. And renin is responsible for converting angiotensinogen, which is produced by the liver, to angiotensin 1. And then angiotensin 1 is going to travel to the lungs. And you have ACE, which is found on the surface of the endothelial lining of pulmonary capillaries. And ACE is going to convert angiotensin 1 to angiotensin 2. And then angiotensin 2 is going to bind to your AT1 receptors, which are found in a variety of places that we'll go over, but perhaps one of the most important places is on the adrenal cortex. And when angiotensin 2 binds to the receptors on the adrenal cortex, it's going to result in the release of aldosterone. And specifically, what layer in the adrenal cortex is aldosterone released from? Do you guys remember? Right, the zona glomerulosa. Good job. Okay, so once you release angiotensin 2, or once angiotensin 2 is converted from angiotensin 1 by ACE, it's going to act to increase blood pressure in two ways. So one way is through aldosterone, and that's going to increase the activity of the basolateral sodium-potassium ATPase, and which eventually results in both hypokalemia and hypernatremia, and we'll go over that mechanism. But then you also have vasoconstriction of smooth muscle vasculature. So I included this picture up here just to help point things out. So you have angiotensin 2 receptors here on the venous side. So when angiotensin binds over here, it's going to constrict the veins. So when you constrict the veins, you increase the amount of filling to the heart. And by doing that, you're going to increase stroke volume, and as a result, increase cardiac output as well as systolic blood pressure. And then over here on the arterial side, you also have angiotensin II receptors. So when angiotensin II binds over here on this side, you get the same thing, vasoconstriction. And if you're constricted on this side, you're going to increase the TPR, which is going to, as a result, increase diastolic blood pressure. Alrighty. I didn't realize he had that animated, sorry. Okay. So I pulled this slide out of Dr. Quadre's lecture, and we'll just walk through it. Okay, so this channel right here, what would you call that channel? I mean, it's a sodium channel, obviously, but it has a special name. Right, that's your ENaC channel. So you have your ENaC channel over here on the side of the tubular lumen of the collecting duct. And this is going to increase the amount of sodium that enters the principal cells. So, and the reason this is happening is because the sodium-potassium ATPase over here on the basolateral membrane. So the sodium entering the principal cells is leaving through the sodium-potassium ATPase pump. And then you're also bringing potassium into the principal cells. So to prevent the principal cells from getting overwhelmed, you have this potassium channel, and potassium is going to leak out into the collecting duct and then eventually enter the urine. And the reason that all of this happens, it starts back here with aldosterone. So when you have an increase in angiotensin II, you're going to increase aldosterone release from the adrenal cortex, specifically the zona glomerulosa. And aldosterone is going to bind to this mineralocorticoid receptor right here. And it's going to act in 3 places. So first of all, it's going to increase gene transcription. And so gene 1 is going to turn on or increase the activity of the sodium-potassium ATPase pump. So as a result, you're going to increase, sorry, if you guys can hear that in the background, I'm sorry, my dog is really wound up, so she's like trotting all over the wood floors. I feel like it's noisy, so sorry about that. So anyways, gene 1 is going to increase the activity of the sodium-potassium ATPase pump, and you're going to increase sodium reabsorption into the blood. And then you're also going to increase the amount of potassium in the principal cells, which will eventually leak out into the tubular lumen of the collecting duct and into the urine. And then, so gene 2 is going to increase the activity of your ENaC channel, which is, of course, going to further drive the activity of the sodium-potassium ATPase pump. And then gene 3 is acting on this potassium channel here, allowing potassium to leak out into the urine. So really, the take-home message from this slide is the fact that if you increase angiotensin II and you increase aldosterone, that's going to result in hypokalemia and hypernatremia. So hypernatremia from the increased sodium reabsorption, and hypokalemia because the potassium is falling out into the urine. All right, is everyone good with that? If not, let me know. Otherwise, I'm going to keep going. Yeah, but up here, here's your main point. Okay. So for the urine, is the opposite right? More potassium in the urine and less sodium. Yep, you're exactly right. Okay, so with hypertrophic cardiomyopathy, this is something that you're going to find in a patient with long-standing congestive heart failure. as a result of a chronically active RAS system. So if someone has a hypertrophic cardiomyopathy, you look over in this picture here, and what is the difference? It's this thick septum and this thickened left ventricle. So if your left ventricular wall and septum are thickened, then you have decreased filling because the size of the ventricle is smaller, and as a result, the contractility of the heart is going to be decreased. So if you decrease the contractility and the heart can't pump as good as it once could, then you're going to decrease the cardiac output, you're going to decrease renal blood flow, you're going to decrease GFR, and you're going to decrease the sodium delivery to the juxtaglomerular apparatus. And then when that happens, of course, you get an increase in renin, increase in angiotensin II, and an increase in aldosterone. So the reason that feeds into hypertrophic cardiomyopathy is angiotensin II is going to act directly on cells to induce the expression of specific proto-oncogenes. And these proto-oncogenes are going to alter the expression of growth factors such as FGF, PDGF, and TGF-beta. So I would be familiar with those. And then, as a result, just saying the same thing again, okay, so angiotensin II, through this mechanism, is going to stimulate the hypertrophy of vascular smooth muscle cells. It's going to increase the extracellular matrix production by vascular smooth muscle. It's going to cause hypertrophy of cardiac myocytes, and that results in what you see over here. And then you're also going to increase extracellular matrix production by cardiac fibroblasts. But, as far as knowing like the pathology of hypertrophic cardiomyopathy and death, I wouldn't worry about that. I would just focus on, this mechanism here in red, how does it happen? And then what does angiotensin II do? So angiotensin II induces, proto-oncogenes that are going to alter the expression of growth factors, and that's going to lead to hypertrophy. All right, so let's get into the drugs. So your DRIs are your direct renin inhibitors, and they are basically doing, exactly what it says. They're inhibiting renin. So if you inhibit renin, you're not getting that conversion of angiotensinogen to angiotensin 1. And the drug that is most often talked about is allostarin. So allostarin is, of course, used to treat hypertension. And one of the adverse effects that you're going to see is hyperkalemia. Because if you think about the mechanism that we talked about with the principal cells, the end result of increasing angiotensin II and aldosterone, it was hypernatremia and hypokalemia. Well, if you're inhibiting the conversion of angiotensinogen to angiotensin 1, you're going to end up with less angiotensin II. So rather than seeing hypokalemia, you're going to see hyperkalemia. And then something not in red, but also that he mentioned, was the fact that allostarin is a teratogen. So it's not something that would be safe for a pregnant female. Okay, so this wasn't in his slides, but this was not something that I really learned or caught on to until late this year. And I think having this mnemonic or knowing it earlier on would have been helpful. So He Loves My Neonate is going to give you drugs or antihypertensive drugs that are safe to use in pregnancy. So hydralazine, labetalol, methyl-dopa, and nifedipine. And this is something that I've definitely seen show up on, the Practice Calmex exams we've taken the past few weeks, and like USMLE practice questions. Yeah, so I felt like this was helpful. Okay. So next we have our ACE inhibitors. So ACE inhibitors are going to end in the suffix pril or prilat. I know last time somebody asked me, how do you remember the names of the drugs? And I think a lot of these antihypertensives are like a bit easier than some of the autonomic drugs, just because, you can follow the suffix. And, if you recognize the pril at the end, you don't even necessarily have to know the full name of the drug, at least when you're, answering multiple choice questions. Okay, so ACE inhibitors are going to act on ACE, and they're going to prevent the conversion of angiotensin 1 to angiotensin 2. And your ACE inhibitors are first line in the treatment of hypertension, and they're also used in patients with congestive heart failure. So a few of your important adverse effects are going to be hyperkalemia, and that's again from the decrease in angiotensin 2 and decrease in release of aldosterone from the adrenal cortex. And then also hypotension, because you're not getting the vasoconstriction on the smooth muscle vasculature. You'll see a decrease in GFR. And why is that? Somebody explain why the decrease in GFR? What is the target of angiotensin 2? The afferent or the efferent arteriole?
Afferent.
Right, so it's going to dilate the efferent, or you lose the efferent arteriolar constriction that you would see with angiotensin 2. Yeah, and then also, so super high yield is the fact that ACE inhibitors prevent the breakdown of bradykinin. So if you have an increase, or not so much an increase, but if your bradykinin isn't being degraded, bradykinin is a potent vasodilator. So you're going to see angioedema. So what is that? What is angioedema? How would you describe that? Right, tongue swelling or face swelling, yeah. And then also, if your bradykinin isn't being degraded, you can also see dry cough. Okay, and then ACE inhibitors are contraindicated in patients with renal artery stenosis, and we'll go over that. Okay, so I just included this slide out of his lecture because I think it's important to realize, exactly what all angiotensin 2 is doing. So it's affecting a lot of different places in the body. So if you have an increase in angiotensin 2, you're increasing the norepinephrine release and the activation of the sympathetic nervous system. You're also increasing tubular sodium chloride reabsorption and potassium excretion, and that's mediated by the aldosterone release from the adrenal cortex. You're also seeing the arteriolar vasoconstriction from the direct action of angiotensin 2 on the arterioles. And then I think one that's at least easy for me to forget is that angiotensin 2 is acting on the pituitary gland, specifically the neurohypophysis, to increase ADH secretion. Okay. All right, so let's go over the drug interaction between ACE inhibitors and a patient with renal artery stenosis. So if you have an obstruction here in the afferent arteriole, that's going to decrease renal blood flow, and as a result, you'll see a decrease in GFR. So sodium filtration is also going to decrease, and less sodium is going to be delivered to the juxtaglomerular apparatus, and that's going to lead to an increase in the secretion of renin, and then go through your pathway and eventually an increase in the amount of angiotensin 2. And then angiotensin 2 mainly has receptors on the efferent arteriole. So angiotensin 2 is targeting the efferent arteriole, resulting in vasoconstriction. And this mechanism is protective in somebody with a renal artery stenosis, because by doing that, you have a constriction here and you have a constriction here, and you're increasing the amount of blood that you can direct this way. So you're not going to increase the GFR, but you are going to maintain the GFR and prevent this decrease that you would see otherwise. So the reason that ACE inhibitors are a bad idea, I guess you would say, in a patient with a renal artery stenosis is because when you give an ACE inhibitor, you're preventing the conversion of angiotensin 1 to angiotensin 2. So if you have less angiotensin 2, this efferent arterial vasoconstriction, that's not going to happen, and you're not going to be able to maintain your GFR. So of course that's going to further harm the kidneys in somebody with renal artery stenosis. So I wanted to go over this just because it's something that comes up a lot in question stems to kind of like tip you off that the patient might have renal artery stenosis. So if you're doing a physical exam and you haven't ordered any tests or anything like that, what is the first thing that you might notice in somebody with renal artery stenosis?
High blood pressure.
Right, but what about when you're examining them? Like, yes, yeah. So Nick's on to something. So, what about when you're using your stethoscope? Like, what are you going to hear when you listen?
Breweries.
Yeah, breweries, exactly. That's what I'm getting at. So a lot of times in question stems, they'll talk about, the patient has renal artery bruits, and they're hinting at renal artery stenosis. So that's kind of a tip off for that. Okay. So now we'll go over our ARBs, so our angiotensin receptor blockers. And, again, this is just doing exactly what it says. It's preventing angiotensin 2 from binding to its receptor. And these are your sartans. So the two I think you said to know for the exam are losartan and valsartan. And they're used, of course, in the treatment of hypertension. And they have a similar effect as ACE inhibitors, but you don't get some of the bad side effects. And then you can also use them in patients with congestive heart failure and MI. But again, two adverse effects are going to be hyperkalemia and hypotension, like your ACE inhibitors. And then I would say if Dr. Quadri did WeBots, this would be one. So if you use an ARB in a patient, you're less likely to see angioedema and less likely to see a dry cough than you would if the patient was being treated with an ARB. If a patient was being treated with an ACE inhibitor, you would be more likely to see angioedema and dry cough. And again, that's because an ACE inhibitor is blocking the degradation of bradykinin. So bradykinin is what's giving you the angioedema. Okay, his WBOT would be that if a patient develops a dry cough on an ACE inhibitor, you're going to switch them to an ARB. And last year somebody asked, well, if ARBs come with fewer side effects, why don't we just start people on ARBs to begin with and, avoid the angioedema or the potential for that? And the reason for that is that ACE inhibitors are renal protective. So that's very helpful in your diabetic patients or patients with like long-standing heart problems. And you'll get a lot more into that next year. But yeah, I would definitely remember this here because I'm pretty sure that was on the test last year. Okay. Catch up with my notes here. Okay, so we talked about adding an ACE inhibitor, but now he's talking about the fact that ACE inhibitors and NSAIDs used together are a bad idea. And okay, so let's just walk through this. So if you have a hypotensive patient or a patient who's losing a lot of blood, you're going to see a decrease in renal blood flow in GFR, and as a result, an increase in prostaglandin I2 and E2, and then an increase in renin and angiotensin II, and this is mediated by prostaglandin I2. So as a result, you're going to see vasodilation of the afferent arteriole and vasoconstriction of the efferent arteriole, which again is mediated by the increase in angiotensin II. So if you have a patient who is hypotensive and you give that patient an NSAID, you can promote renal ischemic damage by blocking the production of prostaglandins. So if you think back to those pathways that we talked about in, I guess it was MFM1. But anyways, so yeah, if you give someone an ACE inhibitor, you're getting rid of that efferent arteriolar vasoconstriction. And if you combine that with an NSAID, you're blocking vasodilation of the afferent arteriole, and you'll see a vasoconstriction instead. So, which, again, is going to lead to a decrease in GFR and, potentially renal ischemia. Okay. Moving on to calcium channel blockers. So I would suggest maybe going back right. Yeah, that is correct. Okay, so I would suggest maybe going back to some of your physio notes and reviewing contraction of ventricular myocyte versus the pacemaker cells. That should help when you get to the antiarrhythmics. But anyways, so if you see an increase in intracellular calcium, that's going to increase the heart rate and contractility and cause vasoconstriction. So we have what are known as positive inotropes and negative inotropes. And your positive inotropes are going to work via norepinephrine activation of your beta-1 receptors. So that sounds familiar from autonomics, right? So that's going to increase contractility. And then your negative inotropes are going to work via acetylcholine release on your M receptors, and these are only found in the atria, and they are going to decrease contractility. So what specifically, he just said M receptors, but specifically which one is going to work on the heart? Which M receptor? 1, 2, or 3? Right, so M2. So important to know is the fact that, so when he uses VD, he means verapamil diltiazem. So they both work on your ventricular myocytes as well as your ipines. And then verapamil and diltiazem can actually work both on ventricular myocytes and your pacemaker cells. And what he likes to say is that verapamil and diltiazem they break your heart, so they slow it down. Okay, so this is kind of like some MFM1 stuff, but just like tying it into pharm. So the pathway where you see vasoconstriction is through an increase in intracellular calcium. So calcium is going to bind to calmodulin. It's going to activate myosin light chain kinase, which, MLCK is going to phosphorylate myosin light chain, and that's going to lead to contraction. And so if you think back to your autonomics, the GQ coupled proteins that mediate this are going to be norepinephrine or epinephrine receptor activation through alpha-1, or you'll also have angiotensin 2 receptor activation, so that's the AT1R that's mediating vasoconstriction, and then also endothelin receptor activation. So vasodilation occurs due to a decrease in intracellular calcium. And so you have cyclic AMP, which is going to inhibit myosin light chain kinase. You inhibit myosin light chain kinase, you're not going to phosphorylate myosin light chain, and you're not going to see contraction. On the other hand, cyclic GMP is going to activate myosin light chain phosphatase. So if you take the phosphate off of myosin light chain, you're going to see relaxation. And this is mediated through GS-coupled proteins, so your beta-2 and your alpha-2 receptor activation. So think back to autonomics, and then also prostacyclin receptor activation. And then also you have the fact that nitric oxide can increase cyclic GMP. And that's important because if you increase cyclic GMP, you're activating myosin light chain phosphatase, taking off the phosphate, and that gives you relaxation or vasodilation. Okay. Yeah, it's just a little schematic. Okay, so your calcium channel blockers. Not skeletal though. I mean, I guess the mechanism is similar, but right. So the mechanism is similar, but this right here is referring to your vascular tone. Yeah, you're welcome. Okay, so your calcium channel blockers are going to be verapamil and diltiazem, and then your dihydropyrimidines, and these would be like nifedipine and amlodipine, I think are the two he focused on. So the thing to remember is that verapamil and diltiazem, they target both your fast and your slow conducting cells. So both the pacemaker cells and the ventricular myocytes. Whereas your IPENs are only targeting the fast conducting cells, so the ventricular myocytes. So one kind of important point is the fact that you want to use caution with beta blockers, because if you're already blocking the SA and AV nodes and then you also use a beta blocker, that's just, that's too much slowing down of the heart rate and the heart's contractility, so that could be dangerous for the patient. And then also the fact that VD is contraindicated in heart failure because of its actions on cardiac myocytes to decrease contractility. So in somebody with heart failure, you obviously wouldn't want to decrease their cardiac output because they're already struggling to maintain that because their heart is failing. And then the thing I would focus on here is the fact that with your IPENs, you can still see that reflex increase in heart rate. Does anyone know why that is? Like, why could you see, reflex tachycardia with your IPENs versus verapamil and diltiazem? You don't.
As you're decreasing your TPR, so your body's going to compensate for that by increasing the heart rate a little bit.
Right, exactly. Okay. Couple practice questions to go over. Okay, so decrease in angiotensin 2 is going to result in which of the following? Right, hyponatremia and hyperkalemia. And this is like a super simple question, but I can't tell you like how many times like they'll write like a really complicated question stem about antihypertensive, and then they'll ask you like, what is the abnormality, like hyperkalemia, hypokalemia, hypercalcemia. So just, think back to that pathway, of aldosterone, on the principal cells, and, that should help you keep this straight. Okay, so if you have a 6-year-old female who's taking lisinopril to treat her hypertension, taking lisinopril will result in which of the following? Right. Good. So the answer here would be D. So decrease in the degradation of, move this out of the way. So decrease in the degradation of bradykinin, and then you're right. So that's going to lead to angioedema. All right. So a 40-year-old male presents to the clinic for his 3-month follow-up appointment. On his last visit, he was prescribed a drug to treat hypertension. He tells you he thinks he might have allergies because over the past 3 months he's had a dry cough that won't go away. You examine him and notice facial swelling and a swollen tongue. Which drug was he prescribed? Yeah, so he was prescribed an ACE inhibitor, which has an adverse side effect of dry cough and angioedema. B doesn't matter. Oh, hold on just 1 second. So the next question, so same stem, you explain to him this is a side effect of his blood pressure medication and you plan to change his prescription. Which drug will you choose? Right, so you're going to choose a sartan or an ARB. And as far as does it matter if you switch to A or D? I mean, as long as it's an ARB, I mean, that will get you like the test question, but like I don't really know how you would choose like losartan over valsartan. That's kind of like beyond where we've gotten at this point. But just for testing purposes, as long as you switch from an ACE to an ARB, you'll be fine. And they won't give you two ARBs as answer choices. So like if you looked at this question, I changed the answer choices to where you just had one ARB. So it would be a similar thing on the exam. Yeah. All right, that's all I've got for you guys tonight. You're welcome. See y'all later. Yeah, happy birthday. Thank you.